Hello and welcome to this session of the Center for Podiatric Education. In this session, I'd like to speak about some of the issues involved in the evaluation and management of patients with wounds, particularly diabetic wounds and venous ulcer wounds, period. Podiatry has become intimately involved in wound care, and we see many podiatrists who are practicing out of wound care centers, and we see a variety of journals with increasing publications by podiatric physicians in the area of wound care. Wound care has become a major market for industry, and we see some very large and successful companies involved in the marketing of wound care products, and many of these companies are quite well known to the listeners. The worldwide market for wound care products is just enormous, and this includes many products beyond just traditional bandages and adhesive dressings. This includes hydrogels and hydrocolloids, alginate dressings, antimicrobial dressings, negative pressure therapy, increasing use of bioengineered skin and skin substitutes, and the utilization of growth factors. If we look at the market for wound care products, again, the annual growth rate is just expected to really grow tremendously, including expanding areas, particularly bioengineered skin and skin graft substitutes, alginate dressings, foam dressings, and hydrogels, as well as antimicrobial dressings, hydrocolloids, and so forth. So we know this is a tremendously expanded market. Some have estimated that the wound care business will be expected to double over the next 3 to 5 years because we have an aging population, we have diabetes, we have increasing frequency of obesity, increasing frequency of venous disease, and a rapidly expanding technology base from which we can select for products to utilize in the treatment of wounds in our patients. One of the things that is concerning, at least to me, is the presence of corporate-driven education. We see the presence of speakers at our seminars on wound cares, and with increasing frequency, these speakers are being paid for in some form or another by corporate support. These may be direct payments to the speakers as honoraria. They may be indirectly given to the speakers through what's commonly referred to as unrestricted educational grants, but in reality, we have speakers who are endorsing various products. We have, if we look at many of the meetings that we attend, breakfast meetings and luncheon meetings, dinner meetings, cocktail parties sponsored by companies with particular products that they would like to advance for our use in the treatment of wounds. We see thought leaders who are increasingly present at our meetings, dinner meetings and so forth, who are paid by corporations making wound care products. And we have to be careful. There's not a week that does not go by that we don't see some article in journals, usually multiple articles in multiple journals advocating new wound care products, telling us about how successful they are at resolving wounds. We see tremendous corporate presence in many magazines and in seminars, and we see corporations not infrequently sponsoring substantial portions of entire seminars and even driving the publication of various journals. so that corporate-driven education, the presence of the influence of corporations in the wound care industry has become pervasive. When I started practice, I don't recall many seminars, very many meetings driven by the topic of wound care. We now have a variety of board certifications and certifications that can be obtained in wound care. Some of these are obtained by simply sending in a membership fee or sending in several cases for review, and you are then provided with some type of certificate or alleged verification of expertise in the area of wound care. So that we see a lot of people with a lot of initials after their names claiming to be holders of experience and knowledge in the area of wound care, when in fact many of these certificates, many of these initials really don't represent a whole lot in terms of actual knowledge or experience. And we see an awful lot of what I would call self-declared experts in wound care. And again, most of these so-called self-declared experts seem to be individuals who are consultants for or large users of product manufacturers, and it's concerning, and we do have to be careful. One of the things that has happened in wound care that I think has partially driven the interest in wound care, quite frankly, is the money to be made by the application of certain products, use of certain products. One can profit substantially by selling wound dressings and wound care products. One can make an awful lot of money by simply taking various products such as skin graft substitutes and applying them to a wound, and several hundreds of dollars can be made per patient each week just by simply applying certain products and billing this as preparation of graft site and preparation of graft and donor site and application of graft and so forth. And this creates a tremendous ethical dilemma, because it does create a bias in that the doctor may be looking to apply various products that they profit from substantially. They may be looking to sell the patient various products, again, that they can dispense for a profit. And it does create ethical behavior issues. We must remember that ethical behavior is something that's inherent to that doctor. And with all the regulations and rules that we could set forth, with all the demands that we can make with regard to the need for ethical behavior for maintenance of licensure, and the bottom line, it comes down to the person themselves. And I do think, at least to my observation over recent years, this has become something of an issue. The other issue is that of standard of care. I was recently speaking at a meeting, and there was a speaker who gave several talks on wound care, and he was sponsored as a consultant for a company that made a particular series of wound care products. And he suggested in the lecture that the failure to utilize advanced wound care products could represent a violation of the standard of care. And some years ago, I recall very well one particular wound care product manufacturer hiring an attorney who lectured at various podiatry meetings, and I was present at several of them, at which again the speaker suggested that the failure to utilize a particular wound care product or similar products represented a violation of the standard of care. Now, this, of course, is a rather serious thing to say, to suggest that not utilizing certain wound care products was in fact essentially malpractice, because this would hold you responsible for damages to individuals who fail to heal and were denied the opportunity to heal because of your negligent care. And we want to remember that the term standard of care is really a legal concept. It's really not a a medical concept. But this is an important issue that I raise, because when we start making demands in terms of wound care and state that patients may lose their limb or become septic or even die as a result of mismanagement of their wounds, then we have a serious problem, because you can be held responsible for damages because of that failure to heal. But standards of care change. They change over time. George Washington died December 14, 1799, of epiglottitis, and he was surrounded by some of the best physicians at the time, and he was suffering with stridor and other symptoms of his epiglottitis, which had been going on for quite some time, several days, and he was being treated by bloodletting, because at the time that was the standard of care. And it had been suggested by at least one physician that they consider a new technique that was being used in Europe, and that was something called a tracheostomy. And in hindsight, it's certainly theoretically possible that a tracheostomy might have allowed George Washington to live a bit longer, but the physicians attending him felt that this tracheostomy concept was simply not consistent with the standard of care, and elected to proceed with additional bloodletting. Unfortunately, Washington died. I often hear attorneys, good attorneys anyway, refer to the standard of care as a moving target, and indeed it is, so that we know that as our knowledge increases, as our knowledge changes, as we clarify various concepts, as new technologies are available to us, the standard of care does indeed change tremendously. If we look at the ulcerations associated with the diabetic foot, I think anyone in the foot and ankle business, if you will, foot and ankle surgeons, podiatric physicians, and so forth, know that the etiology of the diabetic foot ulcer is pretty well known. We understand there are components of repetitive mechanical trauma, compression and shearing, various components of vascular disease, sensory, motor, and autonomic neuropathy. There are skin changes present, nutritional deficits, and deformity, and so forth, that lead this pathway down to ulceration and infection and gangrene and eventual amputation. So the cause of diabetic foot ulceration is well known, I think, to everyone. And the basic concepts of ulcer management are also well known to everyone, so that we know in evaluating ulcers, there are times that debridement is required. There are times that we need to identify and control biomechanical factors, whether they are deformities that require correction or offloading, shoe therapy, and so forth. But pressure reduction is known to be a major component of treatment for certain types of ulcerations. We want to assure as best we can the adequacy of vascular perfusion to allow our best chance at healing. We want to encourage good control of the diabetes. We want to evaluate the patient and control for any obvious nutritional deficits that we feel is contributing to the ulceration. We want to make efforts to reduce bioburden and certainly identify and control any infection present. We want to maintain moisture balance, and perhaps the most difficult thing of all is to obtain patient compliance. But with all our understanding of the basic causes and the basic concepts of treatment of diabetic foot ulcerations, the recalcitrance rate, the recurrence rate of diabetic ulcers remains high. And it has been said by people smarter than I that there are two parts of diabetic ulcer management. One is healing the initial ulcer, and the other is preventing a recurrence, since the factors that caused the initial ulceration are generally still present after we heal that ulcer, and we need to do something to prevent a reoccurrence. The same thing can be said about venous ulcers, and again, looking at the recurrence rate of venous ulcers, we know that they are quite high because the factors that cause that ulcer are still present following our initial treatment. There are also considerations that we have to look at in terms of third-party carriers. We are facing an aging population. Many of the patients that we see are Medicare patients, and as a result, not only must we look at the medical aspects of evaluation and treatment of wounds, we have to satisfy third-party regulatory burdens, those regulations and definitions set forth by Medicare. So Medicare generally defines wound care as treatment of wounds that are refractory to healing, not acute wounds, wounds that have a complicated healing cycle because of problems such as diabetes or anemia and complicated physiologic factors. So wound care in general by Medicare standards does really not include acute wounds or clean wounds that normally would heal under any event, so that we don't look at a person who sustains an acute laceration and expect that Medicare is going to pay for the use of, say, skin graft substitutes that are really intended for the treatment of chronic wounds. In terms of documentation, it's important to consider that Medicare requires that in order to be reimbursed, services should be reasonable, and the documentation should reflect the fact that this service should be necessary. The services should be safe. They should generally be regarded as effective for the treatment of wounds. They should be furnished in an appropriate setting for the performance of that service, so that there are certain services that are considered appropriate to be performed in the operating room, for example, and not the office setting, and they should be administered by appropriate qualified personnel. Now, while this represents Medicare evaluation and recommendations regarding wound care, I think it also represents the ethical treatment of wounds. After all, our treatments should be reasonable, they should be things that are necessary and safe to the patient, and generally we should be doing things that are known to be effective or generally felt to be effective in the treatment of our patients. As I mentioned earlier, one of the problems is that there's tremendous money to be made in wound care by the performance of certain services. For example, the application of skin graft substitutes, or performing debridements, or doing skin flaps, or performing certain surgical procedures. And one of the issues with wound care is similar to medicine in general, and that is it tends to be weighted towards the performance of procedures. And in general, in wound care, as in the rest of medicine, you are paid for what you do, and you are really underpaid for what you do not do, meaning that you don't get as much for an office visit generally, for evaluation of that patient and making recommendations, as you would be paid for performing a service. So there is a bias, if you will, towards looking at wanting to perform some type of service on that patient in order to increase reimbursement. Because of that, the system actually encourages intervention. Another issue is high expectations of patients. Patients with diabetic foot ulcers have high expectations. They don't understand that they are sick individuals, that patients that have ulcerations, whether they are neuropathic or arterial, have associated increased morbidity and mortality, and that are at risk for limb loss and infection and sepsis. And I think all too frequently patients look at a failure to heal a wound as being the failure of the physician or podiatrist to have adequately evaluated and treated that patient. And oftentimes this thought is fostered by subsequent treating healthcare providers who look at the unhealed wound or the complicated wound or the worsened wound and give the patient the old "I would have, I should have, I could have, and I didn't." And this becomes problematic because, again, these are sick patients, and patients need to be told up front that if they have ulceration, they are at considerable risk for complications and sequelae, including limb loss, possibly even loss of life, and that they are indeed at risk. There's also been this explosion in technology. Literally every day I can find some article published somewhere attesting to some new technology, some new dressing, some new skin graft procedure, whatever, that is supposed to be the end-all be-all. And I often wonder why it is we can't heal diabetic wounds. Every study that we see claims 60%, 70%, 80%, 90% successful resolution of diabetic foot wounds. And not only do we see these white papers and studies announced in various journals, online journals, paper journals, and so forth, but the public is told that this technology is available and is going to assist in healing of their wounds. One of the arguments that's frequently made by wound care people is, well, we have to pay the bills, and so of course we're going to do things such as sell various dressings and wound care products, or have a tendency to put the emphasis on procedures because we have to maintain overhead and pay the bills. We also want to remember that wound care centers are profit driven, and we have seen a proliferation of wound care centers, frequently based on the use of hyperbaric oxygen. We've seen these proliferate throughout the country, and they advertise, they attract a large number of patients. And again, we have to remember that above all, wound care centers are corporate-driven, profit-driven centers. And lastly, we have medical and legal concerns that we have to spend time, in my opinion, with excessive documentation. I was reviewing a malpractice case recently, and this was a patient who injured the top of their foot and had essentially a laceration turned ulceration on the top of a big toe. And this was not a particularly complicated wound. It was not significantly infected, and each and every visit to the wound care center was accompanied by 22 pages of notes. And we have all this data that's gathered and put into the medical record, and frankly I think it gets to be ridiculous, and anyone who reviews charts knows that we now have to wade through page after page of drop-down notes, page after page of pre-populated notes, and just an amazing plethora of data. How did the patient get to the wound care center? How are they getting home? Did they wear their seatbelt back and forth? And while you could take any one piece of information and debate and argue its importance as a total, I would argue that a non-infected wound on the top of a big toe is not worthy of 14 visits to a wound care center, each one being 22 pages long in terms of information that is obtained. We also have some practical, legal, and ethical issues. At all times, we want to do what's right for the patient, whether anyone is evaluating our charts or not. Sometimes what's right may not be legal. For example, giving away dressings to patients while charging other patients is right, but at the federal level this may not be legal. Or you may charge by using a code that's not totally accurate, but is the best code for getting the patient covered for procedures for which they otherwise might not be eligible for coverage. And sometimes what's legal may not be right. For example, selling unneeded products in the office because one can profit by selling these products. And indeed, we have speakers and entire seminars devoted to how to sell various products to patients in the office setting, or using unneeded products or modalities. For example, using expensive wound care products or skin graft substitutes when indeed these things are not required. Some other issues that come up, the frequency of debridements. I always like to ask, who said wounds need to be debrided every single week? What we should be doing is evaluating patients periodically and evaluating the wound and determining, first of all, whether or not a debridement is required. And I can't tell you how many charts that I have reviewed in my career where patients were being debrided every 3 to 4 days, once a week, and this went on ad infinitum. And I don't know that there's any data that I've seen to show that, for example, debriding a wound every week leads to superior wound healing. So the determination of the frequency of debridements should really be determined on a case-to-case basis by evaluating the particulars of each case. Similarly, we don't have a standard as to how often wound evaluations should be performed. Should they be performed weekly, every 2 weeks? Perhaps twice in 1 week might be appropriate. And whether or not we can't assign some wound care to caregivers and enlist the family and friends, teach them how to evaluate and manage some aspects of wound care. Who needs to see the patient? Does the doctor have to see the patient on every visit? Is a physician assistant or nurse practitioner or physical therapist or nurse qualified to evaluate and assess wounds, or does it require a physician to see the wound every single time? And then lastly, the need for advanced therapies. And again, I think this has become problematic. Industry is heavily involved in encouragement for the use of advanced wound therapies, and doctors tend to benefit financially, as do corporations, when advanced therapies are utilized. And realistically, we have to balance these financial concerns, which are attractive and I think do create a bias versus what the patient really needs. For example, some research has shown that 47% of miscoded procedures were not actually surgical debridements. So not infrequently reviews show that billings for surgical debridement of an ulcer did not actually meet criteria for surgical debridement, and that oftentimes this became part of an inappropriate pattern. And as a result of that, we've seen increasing regulatory burden for debridement. We're at a point now where we have to describe the width and the depth and the length of ulcers and what the ulcer looks like before and after debridement and what we utilize to do the debridement and the surrounding tissues and all this regulatory burden that goes on and on and on to justify and verify what we think is an appropriate intervention. And I don't believe that this documentation stops abuse. I think all it does is create more paperwork that we go ahead and fill out, because these third parties are not evaluating the patient, they're evaluating the paperwork. And then we have the issue of hyperbaric oxygen centers and wound care. And these have become pervasive. They are financially attractive to hospitals. They are a center of hope for patients who are desperate for healing wounds and worried about loss of their limb. And studies have shown that as much as 32% of all payments from hyperbaric oxygen centers were inappropriate. 11% of all payments are for excessive treatments that simply were not justified. And 37% of the billings from wound care centers lack sufficient progress as reflected in the notes to justify continuing with this treatment. But everyone makes money in a wound care center: the hospital, the physician, the national corporation. We see a lot of products available, and I remember getting a case for review from a law firm specializing in suing podiatrists, and the attorney was on the phone asking me to review a case in which he was going to sue a podiatrist for not utilizing an advanced wound care product. Now, the patient did not lose their leg, but there was some prolonged recovery in healing the wound, and someone had suggested to this particular patient, in this case the plaintiff, that had an appropriate advanced wound care product been utilized, that the wound would have healed faster, there would have been less disability, less time out from work, less financial loss, and so forth. And I really felt there was absolutely no basis for that suggestion in this particular case, but nevertheless, this attorney was arguing his case to me unsuccessfully. But it's gotten to that level where some will suggest that the use of these products or failure to use them is in fact negligent. And as I said, I heard this myself at a recent meeting, and I've heard it before. This concept has developed over time in terms of corporate-driven standard of care definitions. That is to say, we say, well, when should I employ advanced therapies, wound vac, advanced biological dressings, skin graft substitutes, so forth and so on. And the general suggestion that has been accepted throughout wound care is that we start with general standard wound care for 4 to 6 weeks, and we look at that patient and see if they're progressing or not. If they are progressing, then we continue with the successful treatment and educate our patient in offloading and control of edema in the case of lower extremity ulcers, and provide follow-up and try to prevent recurrence. If, on the other hand, after 4 to 6 weeks we are not making adequate progress, then what we should do is not jump to use advanced wound care products, but we should reassess that patient. So if they're not making adequate progress, we say to ourselves, why? Is there something going on that maybe I just didn't adequately assess the first time, or missed the first time, or didn't appreciate? Perhaps the vascular supply is worse than we thought. Perhaps there was a greater bioburden, or perhaps some degree of infection that we did not appreciate. Perhaps the patient has been non-compliant in carrying out the directions for wound care or in offloading. Many other factors. Maybe their diabetes has been under adequate control. Maybe their nutritional status is worse than we had anticipated. So before we jump to a mandate that after 4 to 6 weeks of failure to meet certain criteria mandates the use of advanced wound care products, I would say no. After 4 to 6 weeks, if you're not making adequate progress, reassess the patient first, and let's look at the process rather than saying this wound has not adequately healed. What product are we going to utilize? So we have this acceptance way back in 1999 by the American Diabetes Association of this concept, and this was based on some early work with a particular skin graft substitute, suggesting that at 4 weeks we should use a 50% reduction in the size of the ulceration as our marker, so that if a wound is not healed after 4 weeks, and if a wound has not healed at least 50% after 4 weeks, then we should be concerned. So the suggestion has been really for the last 15 years that 50% reduction in the size of the wound should occur in the first 4 to 6 weeks, and this would be a predictor of eventual healing. The original paper that's often cited actually was that of Peter Sheehan and Associates in Diabetes Care. This was published in 2003, and it became known as the 50% rule. And what was noted by the authors was that if you look at patients who had at least 50% reduction in the size of the wound over the first month, 58% of those patients went on to heal their wound. However, that means 42% did not. Conversely, if you look at patients who had less than 50% healing within the first 4 weeks, only 9% of those patients went on to heal. So there was some basis, at least in one study, to suggest that the 50% rule was a predictor of whether or not a patient would heal. But notice that the patients who healed at least 50%, we're only talking about a 58% healing. And the same thing was noted as looking at foot ulcer area rather than just width and length of the wound. I heard Paul Kim, who is one of our profession's true leaders in wound care, lecturing at a recent meeting, And I had to laugh because I think what he said was probably true, and I laughed because it was just so practical. So I've sort of stolen this concept from Paul Kim. I hope he doesn't mind. He said that if you really look at what goes on, about 50% of the patients that present to our offices with ulcers heal with standard care, assuming, of course, compliance. About 30% of ulcers heal with some additional therapy that goes a little bit beyond standard care. This may include anything from hyperbaric oxygen to skin flaps and grafts and so forth. And about 20% of patients just never heal. They just have very complicated, difficult wounds, and we need to understand that concept, that failure to achieve healing in a wound does not imply failure of that healthcare provider, that there are some wounds that we simply cannot heal. As a nephrology friend of mine once said, he said, Dr. Jacobs, if we could heal everything, no one would ever die. One of my ex-residents said it best. We were talking about wound care and wound care products, and he looked at me and he said, you know, Dr. Jacobs, the way I see it, there's two types of wounds. There are the ones when you walk in the room and you look at that patient, you say to yourself internally, I can heal that wound. And then there are the wounds that you look at in the office and you know internally that no matter what you do, you're not going to be able to heal that wound. And to some extent, I think he was right. I think most of us with experience in wound care get a sense as to our likelihood or probability that with all things being managed, meaning we have patient cooperation, which is a big one to get patient adherence. I think that's probably as big a factor for failure to heal as anything, and if we account for the major factors that we know are operative in healing wounds, we pretty much know when we look at people that we should or should not be able to heal particular wounds. This consensus recommendation was an example of the type of things that I fear the most and has happened in wound care and is starting to make a resurgence again, and I find it bothersome. So there was a product being advocated for adjunctive treatment of diabetic ulcers, and they put together a thought panel, a consensus panel. Now these consensus panels are worrisome to me because they are consisting of people who are paid by a corporation. And generally, in my experience, these concession panels are individuals who use a large amount of the products that the consensus panel is going to discuss. So we know that there's a bias in that the corporations recruit people who are already big users of these products. And these people are paid consultants and paid lecturers. And some of them make hundreds of thousands of dollars a year lecturing for these companies. And they put together a consensus recommendation, in this case on the treatment of diabetic neuropathic ulcers, which included the use of these particular products, some of which were manufactured by this particular company. Well, that's fair enough. Hopefully the readers of these consensus panels will understand the source of these opinions and take it under advice. But this document was taken to various podiatry meetings, and I was in attendance at several of them, and the company hired an attorney. And the attorney would hold up this document and suggest that this represented the standard of care. So now we are injecting a legal concept into the practice of medicine, suggesting that a failure to follow these guidelines developed by a consensus panel of people paid by a company with this potential bias, that a failure to follow these recommendations was in fact malpractice, and that this document could be used against a podiatrist in a court of law. I have always raised my objection to these types of things. I continue to do so because it crosses a line. We understand corporations want to sell a product, we understand corporations want to make their money, but to suggest that a failure to use their products is malpractice is objectionable. And yet this individual was speaking at many podiatry meetings, and again, the corporations give a grant to the meeting to get these speakers in front of the audience in these symposia. And this becomes a dangerous thing, in my opinion. When we start getting corporations involved in these white papers and production of these documents, I think we have a problem because we have too much influence of industry going on in research. And as I said earlier, we have so many wound care products available that supposedly heal these wounds. I sometimes wonder why we're not able to heal diabetic wounds, since literally we weekly read about in podiatry journals new products and some thought leader who's come up with yet another product to heal all wounds. And this affects publication practices, because what happens is between the articles produced and the consensus panels produced and the guidelines produced and the lecturing at meetings produced, marketing becomes disguised as education. And we have lecture commercials rather than true education. And this is done in any number of ways, and it is concerning and should be concerning to our profession. We know that when representatives come to your office from these various corporations to introduce you to various products, they give you white papers and so-called research. Well, we know that industry-sponsored research is 3.5 to 4 times more likely to demonstrate a positive outcome than non-industry sponsored research. And the bias in these trials is pervasive. And we want to remember these are people that are coming to us, meaning the patients coming to us in need. They have a wound, they're frightened, they don't want to lose their leg, and you have to make a decision as to what's best for that patient and balance that with cost containment and try to do the best thing for the money. And it's difficult when you have this type of bias. Many times, if you look at authors, they frequently fail to declare their conflict of interest. And many of these people lecturing at our meetings and writing these articles are being paid as advisory panel members. They're receiving some type of third-party funding. Sometimes they have stock interest and other ownership interests that we're not aware of. They may have particular personal relationships with the corporation, this type of thing, so that oftentimes the motives behind the speaker or author are not clearly defined. Interestingly, many times we as healthcare providers don't seem to care, so that we look at studies and the first thing we look at is, well, how many people healed, and was the size ample size, and what kind of study was it? But we tend not to look at things such as the author's affiliation with the corporation or where the money came from for funding of that study, this type of thing, so that we tend not to look at that. I oftentimes hear people say, well, you know, these corporations could spend all the money they want on wound care products. I'm immune to that. It doesn't influence me in the least. I always do what's right for the patient. Well, a lot of these corporations have some pretty smart people, and the question is really if gifts and dinners and white papers and lunches don't influence you, if free trips to the manufacturing plant don't influence you, then why do companies keep on spending money to do it? Because research shows that preferential treatment is given in response to various gifts and favors and hospitality suites and lunchtime meetings and free samples and so forth. So to suggest that these efforts by corporate America to sway our selection of products for wound care is simply unsupported. It does make a difference. We also have various relationships that create ethical dilemmas between the doctor and the patient, the employer and institution. Whether or not we want to do certain things for patients, but we're fearful of using too expensive a product, and so we avoid using certain things that we should use simply because it's too expensive. Or our relationship with the wound care industry, where we use products because we want to be advisors and consultants with these people. So these are difficult ethical relationships that we have to deal with. And then there's the issue of what do you do when patients cannot afford appropriate wound care? What about when you want to initiate a certain therapy, let's say an intermittent sequential lymphedema pump, or you want to use a certain skin graft substitute that you think is appropriate, but they lack third-party coverage, or the patient can't afford the co-pays or the deductibles, or they can't afford the transportation to get back and forth to your office or the wound care center, or the institution tells you you can't use an external fixator on this patient's Charcot joint because we're not going to be reimbursed enough. And again, here too, it creates ethical issues for all of us as providers and how you're going to deal with that. So in looking at these various papers, probably the least important to me would be the white papers, because they're generally a series of case studies and things that are paid for and sponsored by the corporation. So we have this hierarchy of evidence, and supposedly the gold standard of trials is the randomized controlled trial. And we say, well, what about wound care products that have been subjected to RCTs? Because after all, the random controlled trial is the gold standard. The problem is looking at the random controlled trials, and in particular, the strict exclusion criteria. And if you look at these wound care random controlled trials, oftentimes they eliminate patients who might benefit from these products, but more importantly, it seems to me that oftentimes they exclude patients that actually represent the types of patients you see in your office on a daily basis. This was a particularly good paper by Carter et al., looking at the applicability of wound care randomized controlled studies to general wound care populations, looking at the percentage of individuals who would be excluded from a typical wound care population, so that we looked at patients who were to be included in wound care trials. And this included 8,611 wound care outpatients, and saying, okay, these are patients that actually come to see us with wounds. How many of these patients would be allowed to participate in these wound care trials that are brought to us and handed to us by the reps who are telling us, look how good this product did, and go ahead and use it. So if we look at these random controlled trials that are done for these products, many of these patients have the problems we see all the time. They have poorly controlled diabetes, they have peripheral arterial disease, they have osteomyelitis, they have chronic kidney disease, they have hepatic disease, they have various forms of gastrointestinal disease, history of chronic venous insufficiency and DVT, they're taking corticosteroids, they have Charcot joints, history of cellulitis, local wound infection, they're on anticoagulants, they abuse alcohol. And you could see that if you look at this list, if we were to tell these patients, you cannot come to my office for care if you have any of these problems, let alone multiple problems, you would have no patients to treat. So the reality is these are the types of patients that we see in our offices, and these types of patients with their multiple comorbid conditions would be excluded from these trials. So that oftentimes we look at these papers that are given to us and we see relatively simple wounds in relatively uncomplicated patients, because the complicated patients, the ones we are actually seeing in our offices, have been excluded from these studies. But here again, because of corporate donations and corporate influence, these products are constantly being presented at our seminars. They're constantly being advertised and advocated in printed journals in our profession. And we don't realize, or we need to realize really, that half the wounds that they're probably showing us as having responded to a wound care product probably didn't need the wound care product at all. So here's an example of a paper looking at 188 ulcers, only 54 of which were diabetic foot ulcers. At 20 weeks, so we're getting on half a year, 1/4 of them still had not healed. There was tremendous variation in how often the particular product was applied, between 1 and 8 times. Only slightly greater than half of the ulcers were on the bottom of the foot, which is very common, if not the location most common in the practice of podiatry. The study included so-called diabetic leg ulcers, whatever that might have been. The study included the patients who were allowed to use negative pressure therapy, and over 90% of the diabetic wounds were Wagner grade 1, and I would argue personally that most Wagner grade 1 ulcers do not require advanced wound care products. This study had no control group. It, of course, included standard wound care in addition to the product being studied. It allowed negative pressure, as I mentioned. And if you looked at it compared to other products, for example, the wound care was 12 weeks. The average duration of the wound was 12 weeks versus 20 weeks versus 12 in another study. Here's another look at a product, again advocated for diabetic foot ulcers. This was a small study of 12 diabetic foot ulcers. 8 out of 12 healed at 12 weeks, that's 3 months. There was no change at 20 weeks, and notice that all the ulcers in this study were Wagner grade 1. And so here we're looking at relatively simple, shallow ulcers, Wagner grade 1, and even at 20 weeks, 1/3 of these ulcers remained unhealed. None of these patients had significant vascular disease. None of them had exposed bone or tendon. Additional therapy was allowed to treat these wounds, although no description of that additional therapy was contained in the study. The dressings really weren't specified, and some patients received 2 or 3 grafts, but no criteria were given within the article as to determining why some patients needed more than 1 graft. Jeff Robbins completed an excellent paper which was published in the Journal of the American Podiatric Medical Association in 2015, and he applied the Quiris synthesis program for evaluation of evidence-based medicine. And he looked at the system for wound care products for diabetic and for venous ulceration. So a rating of high indicated that there was so much good data for the use of these products that it was unlikely that additional studies would change your confidence in that product, all the way down to low, which was that the information we had was really not that compelling, and that further research would likely or could very well have an important impact on your decision to use these products or not use these products. And looking at this system and applying it to common therapies, you can see that, for example, commonly used therapies for the treatment of diabetic ulcers generally had very low level of reliability based on the studies and papers that were available, and perhaps the best therapy, they were most supportive with moderate support, was negative pressure therapy, everything else quite low. Looking at products used to treat venous ulcers, again, generally a low level of confidence for the use of these products based again upon the papers that were available for our review. Looking at the International Working Group on the Diabetic Foot, they examined evidence for the use of various wound care modalities published between 2012 and 2014, and you can see that quite a bit of an eclectic array of therapies was examined, all the way from debridement to wound prep to use of oxygen therapy, excision of wounds, applications of various products, use of bioengineered skin and skin products and skin grafts and so forth. And their conclusion was that, with the possible exception of negative pressure therapy, there was little published evidence to justify the use of these newer therapies. And that if you really look at what these people are handing you to consider, controlled studies were few, and most of these studies were of poor methodologic quality. Again, returning us to basic wound care and telling us that oftentimes these expensive therapies for which we and corporations profit the most may not be justified, and we really don't have solid data for use of many of them. I think one of the biggest offenders may be hyperbaric oxygen. Hyperbaric oxygen generates money for the hospital, it generates money for corporations, it generates money for the healthcare providers. And if we were to carefully screen patients and reduce the number of patients who are, quote, eligible for hyperbaric oxygen, close quote, this would reduce hospital revenue, it reduces corporate revenue, and it reduces revenue to the healthcare providers. So again, we have tremendous ethical conflict here. So that the use of hyperbaric oxygen would be best if we excluded wounds that would heal without hyperbaric oxygen and restrict hyperbaric oxygen to wounds that require it only, because if they're going to heal without hyperbaric oxygen, why include it? It is expensive. And don't give hyperbaric oxygen to patients that have hopeless situation. It's not the last station before the train goes off the cliff. The other thing is looking at how wound care centers are constructed and how they are run. Depending on the day and the time you go to a particular wound care center, you might see a plastic surgeon, you might see an infectious disease doctor, you might see a family medicine doctor, you might see a podiatrist, you might see a vascular surgeon. So that the question is, do we really have coordinated care? Because we know that there are many etiologies associated with these chronic non-healing wounds, and each individual has their own specialty, but certainly does not have, for example, an infectious disease doctor is not going to have the knowledge of foot function that, say, a podiatrist would, and the podiatrist is not going to have the knowledge of endovascular procedures that an interventionalist would. And all too frequently we fail to facilitate the services of all the team members working together for the benefit of the patient, which is ideal. So what I'm suggesting is, in many wound care centers, the treatment one receives is very much dependent on the patient and their training the day that they go to that wound care center, whether it's a family medicine doctor, an internal medicine doctor, an infectious disease doctor, an orthopedic surgeon, a podiatrist, a plastic surgeon, whatever. And that treatment's going to vary within the same wound care center, and how the debridements perform, perceived need for surgical offloading, this type of thing, depending on who's seeing that patient. And we have the question of whether wound care is in fact a specialty in and of itself, and whether we need to start requiring residencies just in wound care. We know that we have a variety of organizations that are certifying or claiming to certify people as wound care specialists. Do these necessarily have to be surgeons? Can they be primary care physicians? And again, just a reminder that corporate influence remains tremendously significant. What we need to establish is some type of standard of care with a national wound care database. We need to use that data, synthesize it, and develop guidelines, and we definitely need to run corporate bias out of the wound care business. So, in summary, do these new products make a difference? With all the new products we have they made a difference? And as the author C.S. Lewis says, isn't it funny how day to day nothing changes, but when you look back, everything is different. And in fact, we still have patients that we cannot heal. We still have a high reoccurrence and recalcitrance rate in diabetic foot ulcers and venous ulcers, despite all this tremendous increased knowledge that we supposedly have. So what can happen if we continue to allow corporations to drive our decision making in wound care? Well, the answer is very simple. We're going to be cut out of our ability to utilize advanced wound care products because we're going to make it too expensive to treat wounds. And third parties are going to say no, no, no with increasing frequency because we're spending a lot of money, and the question is, are we really getting better results? And we don't want to have an analogous situation to that referred to by Albert Einstein with this famous quote, We don't want to return to having to treat wounds with just sticks and stones. We want to be able to ethically utilize wound care products, expensive or not, when they are indicated. So we always want to remember the basic principles of ethics in general, autonomy of the patient. We want to always do what's best in the benefit of the patient, do what we can to avoid injury to the patient. And yes, there's a role for standard of care and malpractice and reimbursing patients for damages, but that should not be the driving force. Thank you.